All right, thank you, Beth. Hi, my name is Rob again, and today we'll be speaking about femoral or radial approach and its impact on vascular complications. Which one is it? It's the big green one, right? No, there we go, sorry. This is my disclosure slide. So I figured we'd start out speaking about the new 2021 guidelines published by the ACC. Here we have new recommendations regarding radial and femoral approaches for PCI with a strong emphasis on radial first strategy. This is in response really to strong evidence for better outcomes for the trans-radial approach and trends in cardiology showing an exponential increase in the number of patients undergoing radial artery cath and PCI in practice. So in looking at our two recommendations here, both class 1 recommendations very strong. First one being in patients with ACS, specifically undergoing PCI, a radial approach is indicated in preference to femoral to reduce the risk of death, vascular complications, or bleeding. And new for this year now, the second recommendation, also class 1, is in patients with stable ischemic heart disease. So basically the entire spectrum of CAD patients undergoing PCI. The radial approach is now also recommended to reduce specifically access site bleeding and vascular complications. So a major change coming to our practice with these new recommendations. So when you ask why radial, I think the better question now is why not radial? So many benefits of radial access. It's shown that patients prefer the trans-radial approach while also offering the advantage of earlier time to ambulation, reduced length of stay in hospitalized patients, and obviously the lower rates of vascular and bleeding complications and improved cardiovascular outcomes in the ACS group, all while reducing healthcare costs. So next I thought we'd look at the specific text recommendations from the guidelines to see the studies they used to create the recommendations. So the first big trial is the MATRIX trial. This is a large RCT from 2015 that looked at whether radial compared with femoral access improves outcomes in our patients with specifically acute coronary syndromes. And what we saw was a significantly lower rate of net adverse clinical events in our radial group, including 30-day death, non-fatal infarction, and stroke, again, among patients with ACS. And this difference was really driven by a lower rate of bleeding events and lower 30-day mortality rate. So really improved outcomes for the radial group compared to the femoral group. And then in that first recommendation, again, the second supportive text they shown was the RIVAL trial. And here we looked at patients, specifically STEMI patients, same radial versus femoral access. And what we saw was STEMI patients demonstrated a lower 30-day mortality with a reduction in major adverse cardiovascular events in the trans-radial group. So here in chart A, you can see a pretty big delta between our radial group and femoral group in terms of 30-day death. So improved outcomes for STEMI patients via the radial approach. And I think we saw this come out around 2017, 2018, and this is when we started to see most of our STEMIs being done via the radial approach. And then for our new recommendation, again, for the stable ischemic heart disease group, or spectrum of patients with CAD, the entire spectrum, study looked at radial versus femoral access, and we found the same outcomes, right? In patients undergoing regular diagnostic coronary angiogram or PCI without ACS, the trans-radial approach significantly reduced bleeding and vascular access site complications, although it has not been shown to reduce rates of MACE or mortality rates. So here in practice at the Mount Sinai Hospital Cath Lab, we've seen this growth of radial procedures since 2018 when the first recommendation was made for our ACS groups. And it kind of mimics the data where growth in procedures and a decrease in complications is seen. And now there's a new national benchmark for this year. 45% volume of cases should be done radial because of the new recommendations. And I think Dr. Sharma set our goal at 50%. But already in the first quarter of 2022, we have a very high volume of radial cases, so I don't think we'll have any trouble meeting that goal. So in looking at these complications, sorry for the pictures, I picked the tame ones after lunch, so they found much worse on Google. But femoral complications, most common is the femoral hematoma, right? Occurrence in 1.8% of diagnostic angiograms and up to 4% in interventional procedures. Very uncomfortable for the patient, increased length of stay for patients, as well in severe cases can require blood transfusions or vascular interventions. In radial, we don't see this frequently at all. Reported rate of 0.03% with almost no need for blood transfusions or any type of vascular surgery. Next femoral complication we see is the infection site, infection at the groin site. A rare occurrence, 0.3% is seen, but compared to radial, it's almost non-existent in the radial group. We do not see radial site infections following PCI or angiogram. And this is a case study of a 47-year-old female with a vascular closure device following a cardiac angiogram with normal coronaries. She was discharged the same day, returned to the ED 3 days later with fever, chills, right groin pain, required a 14-day hospitalization with IV antibiotics and wound debridement, still the need for skin grafting after, all which could have been avoided if we asked why are we not going radial on this patient. A little more serious complication now is the pseudoaneurysm. Rare occurrence in diagnostic angiograms around 0.2%, but when we start doing PCIs with larger sheaths, you see like a 2.2% occurrence of femoral pseudoaneurysms. Again, usually requiring some type of endovascular intervention or surgery, and it's just not seen in our radial group. And then the most serious complication of femoral access is probably the retroperitoneal hemorrhage. Very rare occurrence, 0.06% in practice, but when it does occur, we find a 3.5-fold independent increase in 30-day mortality. So when undiscovered, this can become a fatal event and a surgical emergency, and this is something that just does not exist in our radial group. So major femoral access site bleeding was such a problem in interventional cardiology. The SCAI actually created a quality improvement toolkit for the prevention and management of major femoral access site bleeding. And for the prevention, they listed about 9 recommendations, and the first 2 were the most important. And of course, obviously, first recommendation is use radial instead of femoral access for PCI. It's shown with an associated 64% reduction in access site bleeding compared with transfemoral in PCI patients for both non-STEMI and STEMI. But sometimes, femoral access has to be used, and I think the second recommendation was important to point out in that use best practices when obtaining femoral access. Most importantly, ultrasound-guided femoral access. When ultrasound-guided femoral access is used, we see comparable rates of major bleeding and vascular complications between radial and femoral. So using ultrasound guidance is super important to keep complications down in the femoral group. However, we still lack the benefit from things like early ambulation, patient satisfaction we get from the Trans-Radial approach. Now, the major limitations of our Trans-Radial access sites, although there are a few, the major one is interventionalist or operator experience. Operators need the proper experience in radial artery access to be successful in doing angiograms and PCIs. And for this reason, the ACC encourages that all operators gain the necessary experience so they may ultimately acquire the skills needed to have expertise with this approach, because this is now what patients will probably be expecting from operators in the future now when they come in for a cath. Most patients want to go via their wrist and not the groin. Another limitation is potential CABG patients. It was stated, in patients who come in with a high likelihood of CABG, the decision to go transradial versus transfemoral based on the need for a potential radial artery bypass graft can be considered. And then obviously the anatomic or clinical limitations may exist where femoral artery access remains your default strategy. So another common rationalization for using femoral access is for complex interventions. but is this actually shown in the data? So here we have a systematic analysis of left main PCI interventions, radial versus femoral access. And in patients undergoing PCI for left main disease, which can be considered one of our more complex and high-risk PCIs, to no surprise, transradial access has less bleeding and reduced vascular site complications, but also shown to have a reduced in-hospital mortality with a comparable procedural success to the patients in the transfemoral group, and even possibly better long-term clinical efficacy than the transfemoral group as well. So same success rates with much better outcomes for a transradial group, not necessarily left main intervention, femoral access is not always necessary. Again, this is based on operator experience as well. And then our next most complex intervention I think we see in the cath lab is the CTO, chronic total occlusion. So here's another study that looked at radial versus femoral approach, and it was a meta-analysis of 9 studies. And complexity rate of CTOs were pretty similar. They were a little less complex in the radial group, 2.3 versus 2.5 JCTO score. But when looking at our success rates, we see similar success rates in the radial group and the femoral group. But when we look at risk again, access site complications are much lower in the radial group, 0.73 versus 1.79. And then major bleeding again, much lower, 0.18 versus 0.9. And then looking similar risk for coronary perforations, emergency bypass surgery, pericardial tamponade, and in-hospital mortality. So I think what we can take from this is that for complex interventions, they don't always warrant femoral access. But again, we have to consider operator experience if they're comfortable doing PCI via radial. So I think in summary from this presentation, what we should be asking now as nurses in the cath lab, right, is why are we not going radial on our patients for diagnostic angiograms or even PCIs? ACC guidelines now show a radial first strategy for a majority of our patients coming into the cath lab. And this is due to improved patient outcomes, right? Reduction in complications and reduced 30-day mortality, so better survival for patients in the ACS group. Not to mention improved patient satisfaction with benefits of early ambulation, reduced lengths of stay, and overall healthcare savings. And that is it. Thank you.